Good morning, hello, and welcome to our presentation. Today, me and my groupmates, Mathis, April, Cynthia, and Bosco, will be presenting a case study focused on type 2 diabetes mellitus, a chronic metabolic condition that affects millions of people worldwide. The goal of this case study is to explore how comprehensive nursing, assessment, and care planning can support effective management of diabetes and prevent complications. Today, we will be presenting a case study on type 2 diabetes mellitus focusing on Mrs. Sampson, a 58-year-old woman with a complex medical history. Mrs. Sampson presented to the urgent care clinic with complaints of numbness and tingling in both feet, along with a non-healing ulcer on her right heel. She also reported increased fatigue, frequent urination, and excessive thirst, classic signs of poorly controlled diabetes. Her past medical history includes hypertension and high cholesterol, and she is a current smoker. Her family history reveals a strong genetic predisposition to metabolic disorders, with both parents suffering from chronic conditions including type 2 diabetes and cardiovascular disease. Throughout these presentations, we will explore the pathophysiological mechanisms underlying her condition, interpret relevant laboratory and clinical findings, and discuss the rationale behind her medical management. This case highlights the multifaceted nature of diabetes care and the importance of early recognitions and intervention to prevent long-term complications. So on my next slides, I will be presenting to you the risk factors for diabetes type 2. Risk factors for type 2 diabetes. So first, I will discuss about the risk factors of type 2 diabetes mellitus. We have two risk factors, which is the non-modifiable and the modifiable risk factors. According to the Lewis textbook, for non-modifiable risk factors, our age that is greater than 35 years are increasing right now. So there is also a family history of diabetes, high risk ethnicity. It includes African American, Hispanic, Native American, Asian American, Pacific Islander. And also for the non-modifiable risk factors, it has the genetic predisposition. And let's go over to the modifiable risk factors according to Lewis textbook. It's the obesity, physical inactivity, pre-diabetes, history of gestational diabetes, hypertension that is greater than 140 over 90 mmHg, and also for the low HDL or high triglycerides, poor diet, and smoking and excessive alcohol. So as you could see, these are the risk factors that is associated with our case, which is Mrs. Samsam. And for further discussions, I will give you to one of our group mates, Madis, to explain about the pathophysiology of type 2 diabetes.
I'm going to talk about pathophysiology of type 2 diabetes. Thank you, Kay, for your valuable introduction. In our slide, you can see some factors and combination that type 2 diabetes. We know type 2 diabetes develop due to a combination of insulin resistance and beta cell dysfunction. That all of us know insulin is a hormone that helps cells take up glucose from the blood. In type 2 diabetes, muscles become less responsive to insulin, so they don't absorb glucose efficiently after meals. Meanwhile, leaving more sugar in the bloodstream, and the liver continues to produce glucose even after eating, contributing to high fasting blood sugar level. In addition, fat tissue release substances that further interfere with insulin's action. All of these factors together can lead to persistently high blood sugar, as you can see in this slide and in this picture. In response to high blood sugar, the beta cells in the pancreas initially increase insulin also in insulin production to overcome the resistance. However, over the time, constant high blood sugar damage these cells and weaken them. As the beta cell become less effective, insulin production decrease, making it even harder for the body to control blood sugar level. And for next slide, I'm going to talk about some symptoms shows in type 2 diabetes. In this slide, according to Goyal recently scholarly article, we can see some common symptom and clinical manifestation related to type 2 diabetes. Now I'm going to talk about some clinical manifestation related to type 2 diabetes according to Goya recent scholarly article. You can see polyuria, polydipsia, polyphagia, glucosuria during type 2 diabetes. What I'm going to talk about some rationale related to them. When there is too much sugar in the blood, the kidney cannot absorb all of it, so it spills into the urine. This is called glucosuria. Also, when we have sugar can attract water, more urine production, and leading to polyuria. This frequent urination can cause the body patient to lose too much water that makes dehydration also. To make up for the lost fluid, the body sends signal to increase thirst also, leading to polydipsia or excessive thirst. This situation makes the person drink more and more water to stay hydrated. At the same time, even though blood sugar is high, the body cells aren't able to use it properly for energy. This makes the body think or assume it is not getting enough food, or they feel a starving situation that cause polyphagia or excessive hunger. These rationales were related to clinical manifestation and pathophysiology of our type 2 diabetes. Now I'm going to invite my other classmate, who is Cynthia, to introduce the rest of our presentation. Thank you.
Thank you, Madis, for discussing the pathophysiology of the diabetic mellitus type 2. And now we are going to talk about or the diabetic ketoacidosis. And DKA happens when the body doesn't have enough insulin to use for energy, and instead of the insulin, our body burns fat, and also it produces ketones as a byproduct. And basing to our case study lab result, our patient does not met the criteria for diabetic ketoacidosis due to the absence of ketones in the blood or in the urine. And also there is no metabolic acidosis. The P level is normal. And also it shows the plasma insulin detectable is 145 pmol per liter, which is a normal level. So the patient is not diabetic ketoacidosis. And for the next slide, we have here a list of chronic complications for diabetic mellitus type 2. And some of the complications that are listed here is being observed or present with our patient. And according to Pharmacy 2020 article, we have chronic complications for macrovascular, microvascular, and also we have a complications for osteoporosis and stiffness. And this can affect these complications are affecting both large and small blood vessels, as well as the bone health if it's not treated properly. And for the next slide, my colleague will be discussing it for you, which is the diagnostic test.
Thank you, Cynthia, for your presentation. Now I will continue with the diagnostic test. We have many kinds of tests to determine if the patient has a diabetes type 2. We have a fasting plasma glucose. We have a 2-hour oral glucose tolerance test. We have also 2-hour plasma glucose and glycated hemoglobin. In our case study, we use two types of tests to verify and to confirm that our patient has diabetes. Because to confirm that a patient has diabetes, we need to have two positive tests. And the first one was fasting plasma glucose. And to do the plasma glucose, the plasma should not eat or drink for 8 or 12 hours before the test. It can drink only water. And this exam measure the amount of sugar in your blood when it should be at the lowest rate. And the normal value is between 4 and 6 millimole per liter. And in our case study, we can see that our patient has 23 millimole liter is higher. And also we have the second glycosylated hemoglobin. This exam shows the average of blood glucose level of the patient for the 3 months before the test. We do this exam generally after 3 months. And in our case study, our patient glycosylated hemoglobin is 9%, is higher because the normal value is between 4 and 6%. Now I will continue with the expected treatment. We know that diabetes is an incurable disease, and the treatment will focus only on the medication. We will give our patient medication like insulin to reduce the higher blood sugar. We will try also to maintain his weight. He will do physical activity and exercise, and we can see that our patient has obesity. He will need to exercise to reduce his weight. Also treatment is nutrition. My patient will need to his intake because he need to reduce sugar in his food. Yeah, this is to maintain our patient healthy. Now I will introduce my colleague April for the next slide. Thank you.
Thank you for your explanation, Bosco. Now I'm going to talk about the two drugs prescribed in our case study. The first one is metformin glucophage. This medication is used alongside diet and exercise to control blood sugar in patients with type 2 diabetes. Metformin's mechanism of action are unique from other classes of oral antihypertensive hyperglycemic drugs. Metformin decreases blood glucose level by decreasing hepatic glucose production, also called gluconeogenesis, decreasing the intestinal absorption of glucose and increasing insulin sensitivity by increasing peripheral glucose uptake and utilization. It is well established that metformin inhibits mitochondrial complex activity and has been generally postulated that its potent anti-diabetic effect occur through this mechanism. The above processes lead to a decrease in blood glucose, managing type 2 diabetes, and exerting positive effect on glycemic control. There are minor side effects of this drug. It is usually GI related, such as anorexia, nausea, and diarrhea. Next one is rosiglitazone Avandia. This medication is used to lower blood sugars in patients with type 2 diabetes. The mechanism of action of this drug is that it acts as a highly selective and potent agonist at proximal proliferator activated receptors in target tissue for insulin action such as adipose tissue, skeletal muscle, and liver. Activation of PPAR gamma receptors regulates the transcription of insulin-responsive genes involved in the control of glucose production, transport, and utilization. In this way, rosiglitazone enhances tissue sensitivity to insulin. Side effect includes fluid retention and weight gain. To manage Mrs. Sampson's diabetes, the following step can be taken. First is medical management. It is important to tailor the medication choice based on her individual needs, current blood sugar level, and any other health concern. Refer Mrs. Sampson to a dietitian to assist in creating a meal plan that emphasizes low glycemic index foods. Encourage regular monitoring of the blood glucose level at home to keep track of her progress and adjust treatment as necessary. Suggest incorporating regular physical activity tailored to her ability, such as walking or low-impact exercises to improve insulin sensitivity and aid in weight management. Since Mrs. Sampson has a diabetic foot ulcer, emphasize the importance of daily foot care. She should inspect her feet daily for any signs of new sore or infection and keep them clean and moisturized. Encourage adequate fluid intake to manage the increased thirst and prevent dehydration. And educate Mrs. Sampson about diabetes, its complication, and the importance of adherence to treatment plans. Regular follow-up appointments should be scheduled to monitor her progress and make necessary adjustments to the treatment plan. It's crucial to address both the immediate symptom and long-term management to prevent complications. This is the end of our presentation, and thank you for listening.